Hi friends, in today's video we're going to be talking about acute renal failure, and if you like this video make sure to give it a thumbs up and subscribe to my channel. We create nursing content for nurses to help students and current nurses and pre-nursing students along their nursing career journey. So if this sounds like something, you'd make sure to subscribe to the channel, but let's get into it. So acute renal failure. It's a rapid loss of renal function due to damage of the kidneys. It's also known as acute kidney injury. It can be seen in hospitalized patients as well as outpatient settings, and normal adults need to excrete 400 milliliters of urine daily to remove wastes through the kidneys. So the pathophysiology of acute renal failure is not always known, but there can be a few underlying problems. These can include hypovolemia, hypotension, reduced cardiac output or cardiac failure, and obstruction of the kidneys. If there is an underlying problem in the body that is affecting the blood flow, then blood flow to the kidneys will be reduced, and this will lead to decreased kidney functioning because there is inadequate blood flow, and if it's not treated, it will lead to kidney failure. This is a nice chart that summarizes what we're going to talk about today. In acute renal failure, there are 3 different types, there's different causes, and we're going to go through all of this, but this may be a good slide to take a screenshot of and print out just to have a good summary of acute renal failure. So it has 4 well-defined stages: oliguric or anuric, diuretic, and convalescent. Treatment depends on the stage or severity and the renal compromise. Acute renal failure can be divided into 3 major classifications depending on the site. First is pre-renal failure. It's caused by interference with renal perfusion or excessive or too rapid volume expansion. It's manifested by decreased glomerular filtration rate. Disorders that lead to pre-renal failure include cardiogenic shock, heart failure, MI, burns, trauma, hemorrhage, septic or anaphylactic shock, and renal artery obstruction. There's also renal or intrarenal. The causes for this are associated with parenchymal changes caused by ischemia or nephrotoxic substances. Acute tubular necrosis accounts for 90% of the causes of acute oliguria, and destruction of tubular epithelial cells results from ischemia, hypoperfusion, and/or direct damage from nephrotoxins. So again, we'll remember that this one is caused mostly by nephrotoxins. And if we look back to that wonderful chart, we can see the intrarenal, that is the intrinsic renal right here. And these are the different things. So drug-induced, that's nephrotoxic, necrosis, we talked about that. So then there's also vascular changes. So yes, again, good summary. So post-renal failure occurs as a result of an obstruction in the urinary tract anywhere from the tubules to the urethral medius. Obstruction most commonly occurs with stones in the urethra. However, trauma, edema associated with infection, prostate enlargement, and/or strictures also causes post-renal failure. So again, those obstructions. So there are different phases. The 4 different phases of acute renal failure are the initiation, oliguria, diuresis, and recovery. So in the initiation period begins with the initial insult and ends when oliguria develops. The oliguria period is accompanied by an increase in serum concentration of substances that would normally be excreted by the kidneys. Diuresis period is marked by the gradual increase in urine output, which signals that glomerular filtration has started to recover. And the recovery period signals the improvement of renal function and may take 3 to 12 months. So let's go over the different causes. And again, that's all on that chart for you. So just in summary, pre-renal causes are volume depletion, impaired cardiac efficiency, and dilation. Intrarenal causes are prolonged renal ischemia, nephrotoxic agents, and infectious processes. And post-renal causes is urinary tract obstruction. So just a summary of that. So clinical manifestations that we might see are lethargy. So since these waste products aren't being filtered, they slowly accumulate within the body. Dryness, the skin and mucous membranes are dry from dehydration. Central nervous system symptoms, which include drowsiness, headache, muscle twitching, and seizures. And increased creatinine. All phases of acute renal failure will increase the creatinine. So prevention. This involves hydration. By providing adequate hydration, we can reduce the risk for dehydration. Shock, so we want to prevent and treat shock promptly with blood and fluid replacements. We want to monitor closely central venous and arterial pressures and hourly urine outputs of critically ill patients to detect the onset of renal failure as early as possible. Blood administrations will take precautions to ensure that the appropriate blood is being administered to the correct patient in order to reduce and avoid severe infusion reactions. Infections, we want to prevent and treat infections because they can progress renal damage. And toxic drug effects, we want to prevent toxic drug effects by closely monitoring doses, durations, and blood levels of all medications metabolized or excreted by the kidneys. Different complications that can occur in acute renal failure depends on the duration and severity, but they can include metabolic acidosis. Waste products could be eliminated by the kidneys, and they can contribute to, so if these toxins can't be eliminated by the kidneys, then, or just waste products in general, then they can cause the metabolic acidosis. And fluid and electrolyte imbalances may occur due to hemorrhage, renal loss, or gastrointestinal losses. So let's look at the assessment and diagnostic findings. So the first thing we can look at when assessing for acute renal failure is the urine. We can look at the volume. Usually during the anuric phase, there's less than 100 milliliters in a 24-hour period, but during the alduric phase, which occurs 24 to 48 hours after renal damage, you'll see 400 milliliters of urine in 24 hours. We can look at the color, so it may appear dirty, it may have brown sediment, which would indicate the presence of red blood cells, hemoglobin, myoglobin. And we can look at specific gravity, so anything less than 1.020 reflects kidney damage. We can look at pH, so greater than 7 found in urinary tract infections, renal tubular necrosis, or chronic renal failure. We can look at osmolality, so less than 350 is indicative of tubular damage, and urine serum ratio is often 1:1. We can look at creatinine clearance, so renal functioning may be significantly decreased before the BUN and serum creatinine show significant elevation. Creatinine clearance. Sodium usually is increased more than 40 if the kidney is not able to absorb sodium, but in pre-renal failure, it can also be decreased. We can look at the fraction sodium. So this is the ratio of sodium excreted to the total sodium filtered by the kidneys. And this will show if the tubules are unable to reabsorb the sodium. We can look at bicarbonate. It'll be elevated if its metabolic acidosis is present. We can look at red blood cells to see if they may be present because of infection, stones, trauma, tumor, or altered glomerular filtration. We can look at protein in the urine. High-grade proteinuria strongly indicates glomerular damage when red blood cells and casts are also present. Low-grade proteinuria and white blood cells may indicate an infection or interstitial nephritis. And we can look at the casts, which signal renal disease or infection. So in the blood, we can look at the BUN and creatinine. So elevated and usually rise in proportion with a ratio of 10:1 or higher. In acute renal failure, we can do a CBC and look at the hemoglobin, which will usually decrease in the presence of anemia. Red blood cells often decrease because of increased fragility and decreased survival. We can look at arterial blood gases. We can look at metabolic acidosis. If the pH is less than 7.2, this can develop because of decreased renal ability to excrete hydrogen and products of metabolism, and the bicarbonate can be decreased. We can look at the sodium, which usually increases but may vary. We can look at potassium. Usually this will be elevated related to retention and cellular shifts because of acidosis or tissue release because of red cell hemolysis. We can look at chloride, phosphorus, and magnesium, all of which are usually elevated. Calcium usually is decreased. Serum osmolality will usually be more than 285. It's often equal to the urine, and protein can have decreased serum levels and may reflect protein loss via urine fluid shifts, decreased intake, or decreased synthesis because of lack of essential amino acids. So there's different imaging we can do when we're assessing these patients as well. So radionucleotide imaging can reveal narrowing and decreased delayed filling or emptying as a result of acute renal failure. It can reveal catalectasis. We can look at the kidney and bladder x-ray, also called a KUB. This demonstrates the size of the kidneys, ureters, and bladder in the presence of any cysts, tumors, abnormal kidney displacement, or obstruction such as stones. We can look at retrograde pyelogram, which outlines abnormalities of the renal pelvis and ureters. We can look at a renalgram, which assesses renal circulation and identifies extravascular masses. We can have a voiding cystoureterogram, which shows bladder size, reflux into the ureters, and retention. We can look at a renal ultrasound, which determines the kidney size, presence of masses, cysts, obstruction in the upper tract. We can look at non-nuclear computed tomography, or a CT scan. This is a cross-sectional view of the kidneys and the urinary tracts, detecting the presence and extent of disease. We can look at an MRI, which is a magnetic resonance imaging, which provides information about soft tissue damage. We can look at excretory graphy, which is a radio plaque contrast concentrate in the urine and facilitates visualization of the KUB. We can look at an endourology, so a direct visualization may be done of the ureters, bladder, urethra, and kidneys to diagnose a problem, biopsy, or remove small lesions or calculi. Or an ECG we can look at because it may be abnormal, reflecting electrolyte and acid-base imbalances. All right, so for diagnosing, we can again look at some urine, but this time tests. So we can look at urinalysis. This can offer insight into the function of the kidneys. We can do a 24-hour urine test, which requires you to collect your urine for 24 hours consecutively. It will be analyzed for protein and waste products such as nitrogen, creatinine, and urea. The presence of protein in the urine indicates kidney damage. The amount of creatinine and urea excreted in the urine can be used to calculate the level of kidney function and the glomerular filtration rate. We can look at the glomerular filtration rate. It expresses the overall kidney function. As kidney disease progresses, glomerular filtration rate decreases. The normal glomerular filtration rate is about 100 to 140 milliliters per minute in men and 85 to 115 in women. It decreases in most with age. Then we'll talk more about this when we talk about chronic kidney disease. So urine-specific gravity, this is a measure of how concentrated the urine sample is. A concentrated urine sample would have a specific gravity over 1.030 or 1.040. So we can also diagnose using blood tests. So we can look at creatinine and urea, BUN in the blood. Blood urea, nitrogen, and serum creatinine are the most common blood tests to screen for and monitor renal disease. Creatinine is the breakdown of normal muscle. Urea is the waste product of the breakdown of protein. The level of these substances rise in the blood as kidney function worsens. We can also look at electrolyte levels and acid-base balance. Kidney dysfunction causes imbalances in electrolyte, especially potassium, phosphorus, and calcium. High potassium, also known as hyperkalemia, is the most concerning because it can cause cardiac arrhythmias. The acid-base imbalance of the blood is usually disrupted as well. We can look for decreased production of the active form of vitamin D, can cause low levels of calcium in the body, and the inability to excrete phosphorus by failing kidneys causes its level in the blood to rise. Blood cell counts, because kidney disease disrupts blood cell production and shortens the survival of red blood cells, the red blood cell count and hemoglobin may be low, so you may see anemia. And some patients may have an iron deficiency. Other tests we can look at are ultrasounds and biopsies. So ultrasounds are usually used to diagnose kidney disease, and it is a non-invasive type of test. In general, kidneys are shrunken in size in chronic kidney disease, although they may be normal or even larger if they're caused by polycystic kidney disease, diabetic neuropathy, and amyloidosis. Biopsies, they'll actually take a sample of the kidney tissue, and they can do it under local anesthesia, and they put a needle through the skin to take a small piece of tissue. So what can we do? The medical management of acute kidney failure includes pharmacological therapies. KLX can reduce elevated potassium levels. IV dextrose and insulin and calcium replacement may be administered to shift potassium back into the cells. Diabetic agents are often administered to control fluid volume. Diuretic agents are often used to control fluid volume. Nutritional therapy replacement of dietary protein is individualized and can provide maximum benefit and minimize uretic symptoms. Calorie requirements are met with high carbohydrate meals. All right, nursing assessment. So we will assess urine output varies from a small amount to a normal volume. We can assess blood in the urine. Hematuria may be present in patients with acute renal failure, and assess laboratory results. Nursing diagnoses, these are just some examples. So electrolyte imbalance related to increased potassium levels, or risk for deficient volume related to increased in urine output. Nursing care plan goals, so we want to improve nutritional intake, restore fluid balance, reduce metabolic rate, promote pulmonary function, and prevent infection. Nursing interventions, we want to monitor fluid and electrolyte imbalances. We want to reduce metabolic rate, so bed rest is encouraged and fever and infection are prevented or treated promptly. We want to promote pulmonary function, so we will assist the patient to turn, cough, take a deep breath. We want to prevent electrolysis and respiratory tract infections. We want to prevent infection, so aseptic technique. We want to provide skin care, so bathing, frequent turning, keeping the skin clean and well moisturized, keeping fingernails trimmed, and providing safety measures. Patients with CNS involvement may be dizzy or confused. evaluation. So we will, these are just some examples: improve nutritional intake, restore fluid balance, reduce metabolic rate, promote pulmonary function, and prevent infections. Discharge and home care guidelines. So nutrition, we want to refer them to a nutritionist because of the dietary changes required. Problems to report. The patient and family must know the problems to report to the healthcare provider and include follow-up exams. Documentation guidelines. We want to make sure that we document vital signs, muscle strength and reflexes, results of any laboratory or diagnostic tests, degrees of deficiency and current sources of fluid intake, I&O and fluid balance, plan of care, teaching plan, the client's response to the treatment, teachings and actions, attainment of progress towards outcomes and modifications to the plan of care, and their long-term. If you guys like this video, please make sure to give it a thumbs up and subscribe below, and check out down below. I have a bunch of free content for you guys, a lot of study guides, pharmacology notebooks. I do also have an NCLEX study guide that you can check out. All of those links will be down below. See you guys next time. Bye.